by the just started recording. Thank you. We were started over 30 years ago by the physicians at the Iowa Heart Center, and as an organization, we focus on heart health education and heart disease prevention across the state of Iowa. I'm happy to introduce Brian Rayhons. He is the deputy. Oh geez, I'm stuttering so much. Sorry. The deputy chief of the West Des Moines EMS. So I will let him start his presentation, and if anyone has any questions, you can ask them in the chat, and we'll do a little Q&A session at the end. So I will hand it over to him.
Perfect. Thank you, Caitlin. Yeah, as Caitlin said, my name is Brian Rayhons, and I am the Deputy Chief of Training and Quality Management for the City of West Des Moines EMS services. And so we are an ambulance service, but we do so much more than just drive the ambulances. And so today, really, that's what I want to share with you. But I also want to incorporate kind of what bystander CPR looks like. And even if you don't know bystander CPR, what happens when 911 is called. So a lot of people, when I say, what is EMS? They say, well, it's the ambulance. Well, you're right. We do drive the ambulances, and contrary to most nurses, we are not just ambulance drivers. We do have quite a bit of training, and we do a lot out in the community. So I just took a minute to gather a bunch of pictures here to kind of showcase what it is that we do. So we do respond to ambulance calls. You call 911, we come out. And in the middle there, you'll see, so I grab my laser pointer. This is kind of the triangle that we see a lot of times of what really describes EMS. And we are kind of a mixture of healthcare, public health, and public safety. So we kind of have fingers in all three of those different realms. Whereas you look at police departments or fire departments, they are public safety. You look at home health care, they are public health. And or your county public health, they are public health. And then you look at the hospitals, and they are truly healthcare. And we kind of fit a little bit into all three of those molds. We provide all of those things. And so up here in the corner, you'll see this is our Assistant Chief, Mark McCulloch. He's doing a interview for CPR. I believe it was Heart Month in one of the past years. And he's showing how easy it is to do CPR and how easy it is to learn CPR. The next picture here, this is our incident command training. So this is the back of our supervisor vehicle, and at large incidents, we will operate out of it and be in an incident command role. Next, we have our paramedic Pete. He is a talking dog that has an ambulance that drives around, and we go out, we go to preschools, daycares, occasionally elementary schools, and we talk about just similar to kind of what we're doing now, but more on the little kid level of what to do if an emergency occurs. And on the far side, we have our EMS memorial. We house that here at the City of West Des Moines, along with our honor guard. We have our own honor guard team members here. Down low, we do training on the ice. So that's one of the fun things that we get to do. We get to interact with the public and go out and do ice training down at our Recplex here in West Des Moines. We go out, we do football training. We cover triathlons. We have our own bike team. So aside from riding an ambulance, we get to ride around on bicycles at different events. Up here, we are landed with the University of Iowa helicopter because we're over in Iowa City and we're participating in their paramedic school. We go over and we assist their students in learning about furthering their education to becoming paramedics. And then in this yellow suit, that's actually me many years ago, but we have a highly infectious disease transport team. And so we travel all across the state. We're one of three or four teams across the state that will transport highly infectious patients. And as you can see, we wear everything down to a respirator, and we take care of those patients just as we normally would. So that's kind of what what EMS encompasses. We talk about what is an ambulance. It's a box, it's a vehicle that you can ride in, but there's a ton of equipment. I really don't like saying that it's an ER on wheels because we are not physicians, and nor are we mid-level practitioners, but we are paramedics, and we do have decision-making capabilities. But this is what the back of the ambulance looks like. In the middle here is our stretcher or our cot. That's how we move patients. That's how we secure them. There's lots of seat belts to it for safety. But as we start looking around, there is a lot of equipment in here. There's a lot of drawers, and these ambulances were designed so that way we could sit in this seat here or over here and be fully seat belted and still be able to access all of our equipment that we need. So that way, while we're moving down the road, we are safe, just as safe as the patient. And I can tell you, when I started in EMS almost 20 years ago, um, I never knew that there were even seatbelts in the back of the ambulance. So we've made great strides in safety for our providers in the back of the ambulance. Over here, just some more pictures. This is called a stair chair. We can go up and down stairs with it. It has a battery to it. It has grips on the back, and so we can move people up safely up and down stairs, saves our backs. And then this is our cot when it's fully out. When I said there's a lot of equipment in the back of our ambulance, we have scales on all of our cots, so we know exactly what patients' weight is, so we can treat them based on that weight and provide different medications. We have IV pumps. We have ventilators, advanced ventilators. In this case, they're providing high flow nasal cannula to the mannequin. Something that came about big during COVID times, but we've continued to use it, and it's one of the therapies that we can offer with that ventilator. This is our defibrillator, our version of the AED. It's manual, and we will tell it when we want it to shock and when we don't want it to shock. But we can also do other things like blood pressures and pulse oximetry with that. And then lastly, up here in the corner, we have our Lucas device. Our Lucas device is an automated CPR device. So as I said, when we are in the back of the ambulance, we want our providers to be safe as well. And so even when we have somebody who is in cardiac arrest, we want them to be our providers to be safe. We want to take really good care of the patient, but we want our providers to be safe because we want everybody to go home at the end of the day. And so we provide automated CPR as opposed to one of us having to stand up to provide CPR. That means that we're not seat belted. That means if there's a hard stop, we're getting thrown into cabinets or doors. If I was to go back to a picture here, you can see like there's the oxygen flow meter here, there's corners. All those things are known to cause major injuries. So as much as we can stay seat belted, we like to stay seat belted. So who is it that works on an ambulance or works in EMS? And there's really about 5 different levels. So we have from the very basic first responder. As a first responder, they can bandage things, they can run the AED, they can provide CPR, or they have CPR training, very limited training. They cannot function on an ambulance by themselves. The minimum level that you can function on an ambulance is at the EMT level. So as we see a lot of these smaller town ambulances and some larger cities, they run ambulances that just have EMTs on them. And so what can an EMT do? They can do all the things that the first responder can do. But really, they can't break the skin. That's how I like to differentiate them. They can't break the skin. So they can't do IVs. They can't put in air. They can do blind airways. So what we call as an iGel or a King LT. They can place those, but they can't break the skin. An advanced EMT can do a few more things. They have a subset of medications that they can administer. And then there's the paramedic. The paramedic can do a lot of things. They can intubate, they can push lots of different medications. They can start IVs, they can do intraosseous. So that's putting it, when we can't get IVs, we can put needles into people's bones and administer medications that way. They can run the ventilator. So they can do a lot of different things. And that's usually about a 2-year program through a local community college that somebody would have to take compared to the EMT, which is about a 120-hour course. For myself, I took it in high school as a high school senior. You do have to be 18 years old to be able to sit for the exam, but as a high school senior, I was able to take night classes and complete my EMT. And then there's the next level, which is in Iowa here, we have what's called critical care paramedic, and that's an endorsement. So you're still a paramedic, but you've taken the extra steps to get a little bit more knowledge. Really doesn't give you any more skills, but it gives you some more knowledge about the human anatomy and physiology and helps you really understand why we're doing what we do. So I thought that every year we do kind of a fun year end review. And I just found this very interesting because a lot of people, when you hear ambulance or see an ambulance on a TV show, there's a lot of blood, there's a lot of gore, there's a lot of bad things that are happening, car accidents, that sort of thing. When in reality, we don't go on that stuff all that very often. We do, so you have to be able to handle that kind of stuff. But in reality, you can see these are our numbers for 2024. So in total, we ran approximately 7,300 trips. 462 of those we had as a diagnosis of generalized weakness. And then second place was abdominal pain, followed by chest pain, discomfort, altered mental status, and then syncope and fainting. So as you can see, a lot of those are pretty, what I like to consider not super serious, can be serious complaints, but they're not what we see on TV. And so they're not what people typically think of when they think, oh, an ambulance is coming. So now is the part where we're going to kind of talk about the day in the life of an EMS provider. And I am truly basing this off of here at West Des Moines EMS. We work 12-hour shifts. So we switch at 7 a.m. and 7 p.m. every day. And we do that for crew safety. We used to do 24-hour shifts, and we were just having a lot of fatigue due to our call volume. And so we made the switch to 12-hour shifts, and crews are very happy with that. So just take that into account, that this is a little bit different depending on where your ambulance is responding from, or where it's located. Some of them are fire-based. We are co-located with the fire department. But we are not a part of the fire department. So we're still two separate departments. And so around 6:45, 6:30, 6:45, our shift change begins. The new crew, this could either be 6:45 a.m. or p.m. The new crew comes in, they're ready to go. They start their shift change. They just kind of start talking with the off-going crew, asking, what did you guys do the night before? Is there anything broken? Just kind of giving them a generalized update. If they were on the day before, this may be quick, less than 5 minutes. Whereas if they've been off for a while, or they haven't been at the station for a while, it may be a little bit longer, just so that way they can become reacquainted with everything. And so really the big handoff that occurs here is that the radio and the phone are passed to the new person. So each provider has a radio on their hip. That is our primary means of dispatching. And then we also have a cell phone that comes with each crew. And the reason that we have that is because, as you can see, the app that's pulled up on there, we utilize an app called Pulsera here in the Des Moines Metro. And Pulsera allows us to notify the hospital that we have a patient coming. And so we can choose all of these different patient types. And depending on which patient type that we choose, so across the top, we have a STEMI, we have a cardiac arrest, we have a stroke, we have trauma, and then we have general. There's a couple more. We don't use the other ones. But what happens is, if I think somebody's having a stroke, I can put it in as a stroke alert. And that's going to notify all of the people that are involved within a stroke alert. So the CT scanner, the neurologist, the stroke coordinator, all those people will be notified at the same time via this app. And so it's really handy and really improves the times from start to finish with that. At around 7 o'clock, we perform a truck check. Every single shift change, there is a truck check that is done. And so we are literally, if I was to go back to that first page, we are going through each cabinet, making sure that all of the correct equipment are there. They are charged. So if, our defibrillator, our Lucas device, our IV pumps, we want to make sure that they are all charged and ready to go. And then we're making sure that we have all the medications. We have a specific PAR level that we need to be at. And so we are checking for those. And then we also make sure that the ambulances are ready and in good working order. So checking things like the fuel. Occasionally people will check the oil, but we really leave that to more of the mechanics to make sure that that is working. But we want to make sure that we can get out the door and get to your emergency. And then every single day at 7:30 or AM or PM, we have a shift briefing. And so that's led by our division chief. And so they hop on a Teams call or our equivalent of a Zoom call. And it's the entire shift unless somebody's out on a call. And it's led, as I said, by the division chief, who is our shift supervisor. And on those calls, they're kind of given an operations update. What's going on? Do we have any students today? We have a lot of paramedic students that come and ride through our organization. We have residents that come and ride. We have occasionally flight nurses, flight paramedics that will come and just they're becoming acquainted to the EMS organization, and so they'll come and ride with us. Gives us the eyes and the building rapport with other healthcare specialties, so that's kind of fun. But we also do a lot of PR, as I showed in the initial set of pictures. And so that kind of includes under that operations updates. What's going on for the day? Is there anything big going on within the city that we need to be aware of? Are there major road closures, detours, etc.? Along with that, usually during the briefing, there's a protocol review and an SOP review. So daily, one of the things that we'll talk about is that we operate off of protocols. So we have a medical director that oversees all of our protocols. And so it's not just us out here making decisions based on what we feel. We have a standard set of protocols that as we start to make clinical judgments, we base it off of those protocols. And then the SOP, just similar to the protocols and everywhere else, we operate off of policies. And so it's always good to review those. So around 8 o'clock, daily activities start. So we're here for 12 hours. There's lots of different things. It could be breakfast time. But every single day there's training, whether it be online or in person. We do a lot of training. I think last year we found that each person gets approximately 60 hours of formal continuing education. That doesn't include other things where somebody might have some informal training going on. So when I say formal hours, it means that me as the training coordinator has set this up, given an outline, and gotten credits through an accrediting agency. The other thing is CQI activities. So we review 100% of our calls. So the oncoming crew reviews the night before's calls. And then driving familiarity. As we are a growing city, and even in the areas that we're not growing, we like to get people out and drive them so that way they can make sure that they know where they're going in an emergency. So at 9:08, crew members are eating breakfast and doing some online training. And meanwhile, while that's going on, the Valley West Mall store owner, Jamie, is opening her shop. Jamie hears frantic calls for help down the corridor. As Jamie arrives to commotion, she notices someone laying on the ground, and someone is shouting that they are not breathing. So these were a bunch of mall walkers, and all of a sudden, one of them collapsed, and they are not breathing. Jamie quickly recognizes the male on the floor is not breathing and begins putting her CPR training to use. Being a shop owner, Jamie felt it was good on her to learn CPR just in case one of the patrons that came into her store happened to just do what happened to this male and collapse. Meanwhile, part of that emergency activation, she tells somebody that they need to call 911. They already have their phone out calling 911. Our dispatch center is Westcom, and they are actually called telecommunicators. They answer the phone and immediately ask for the address and what is wrong. So as you can see, my timestamp up there at 9:09 and 30 seconds. The person calling says someone is not conscious and they don't think that they're breathing. That immediately start entering information. So as they ask questions, they're entering information. You can see that they have a lot of different computer screens, and this is a fairly old picture. Now they have one gigantic, it's probably like a 55-inch TV that sits in front of them, and they have all these screens just in one. At 9:10, so less than 30 seconds after the first phone call comes in, they hit enter on their console and it automatically dispatched. So when we have our radios out, we hear a computer automated voice. Um, and so what they say is engine 210, ambulance 173, car 199, unconscious patient, 1501 Valley West Drive, and they repeat it. And then they also dispatch police officers. So West Des Moines units, EMS and fire are going for an unconscious patient, 1501 Valley West Drive, 4104 and 4106. I have you on the call. So that is kind of what we would hear over the radio if we were truly responding to this call. Meanwhile, since I said that that's all computer automated, that leaves the telecommunicator to continue asking questions. So in their mind, somebody is already providing CPR, but they're also going to ask questions such as, are they breathing? Do breathing diagnostics. So they will ask you over the phone, tell me when they breathe. And they are going to hit enter or a key on their keyboard each time that you say that they breathe, they're taking a breath, or that you think that they're taking a breath. And what that does is the computer works through a system and says, okay, they're breathing 4 times a minute. And we know that that's not sustainable to life. So they are going to start to give you CPR instructions over the phone. And that's very simple. They are going to tell you to get the patient onto a hard surface. They are going to tell you to where to put your hands and how far to press, and they're going to tell you when to press. The other thing that they're going to ask is if you know if there is an AED around. So it may be that you're in a public space and they may know where that AED is based on maps. Or if somebody that is there knows where an AED is, somebody can go and get it. So they're going to prompt you for all of these things. So that's kind of what happens if, in our case, in our little scenario, Jamie already knew CPR. But as I just said, I got ahead of myself. If Jamie didn't know CPR or wasn't around, as you call 911, they are going to walk you through step by step how to perform CPR, because bystander CPR is so important. I can tell you that out of all of our cardiac arrests, because we keep very detailed data, those that do not have bystander CPR, there's a very, very low percentage of those patients that survive, and our response time is approximately 5 minutes and 30 seconds anywhere within the city of West Des Moines. And so that time is from when you start dialing 911 to us arriving on scene. And we know that the longer somebody's brain goes without blood, or their heart stops beating and is not providing oxygenation to the heart and the brain, the less likely they are to survive. So we find it very important that our dispatchers give the CPR instructions. So this is a little bit of a map of where all of the responders are coming from. So right here, this is our simulated cardiac arrest. This is the fire engine location. This is the ambulance. And this is our supervisor. So West Des Moines getting to be big, and so it will take us a little while to get there. Unfortunately, we can't have an ambulance or a fire truck on every single street corner, but we also have the 2 police officers. So this is a police officer and this is a police officer. So again, I just cannot stress how important it is for bystander CPR, because no matter where you're at, it's going to take us a little bit to get there and assist with CPR. Each one of our police cars have an AED in it, so that is good. So if they weren't in a public place and this police officer happened to be closer than the fire truck or the ambulance, they would be able to provide that early defibrillation. So quickly, the dispatcher upgrades the call to a cardiac arrest. So we went from an unconscious patient, they went through their breathing diagnostics, and the caller told them, hey, the shop owner is providing CPR. Quickly, they're going to upgrade that to a cardiac arrest. They would put that out over the air. West Des Moines units, unconscious patient has been upgraded to a cardiac arrest. Another police officer just happened to be clearing a traffic stop less than 1 block away and responds. And so, as I said, Westcom continues to talk to the caller, giving CPR prompts, moving the patient prompts, comforting the caller, letting them know that EMS, fire, and police are on their way, kind of giving them like, hey, they should be walking in. Can somebody go down to the door and flag them down? What is the best entrance to access? They're going to ask a lot of these questions, so that way when we do arrive, it's not confusing for us. When we respond to somebody's home, it's fairly simple. Usually we use the front door, but at a large public space like a mall, there's many different doors and it's hard to know where we should go. So the first police officer arrives on scene in about 2 minutes from the first 911 call, retrieves his or her AED, and runs inside. Immediately takes over CPR from the bystanders. And then the other two police officers arrive. They apply the AED and provide support to the patient's wife, who was a bystander, while gathering information. So they are immediately going to start asking what was going on before. Does this patient take any medications? Do they have any history? They are really good at getting that information from the patient or the bystanders prior to us getting there. At 9:13, the first fire truck arrives. It has a crew of 4 firefighters and EMTs. Some of them may be paramedics, but they grab their AED and their first out bag and they head inside. They immediately start CPR. Meanwhile, our ambulance and supervisor arrive on scene at about the same time. They gather up all of that equipment and go to the patient. So now we're all at the patient. We have a lot of people in place. Now what happens? As I said, we work off of protocols. This is our actual cardiac arrest protocol. Our main focus up here is CPR, providing amazing CPR and basic airway management, and then defibrillating the patient as we need. And so this is how we operate. And then as our paramedics come in, we start to escalate down through here. We'll give epinephrine, we'll shock as needed, and treat all the underlying potential causes. The reason I show this is because when somebody suffers cardiac arrest, we actually leave them right where they're at, and we are going to work on the patient right there or care for the patient right there. The reason that we do that is because as we start to try to move the patient or try to go up and down stairs or etc., we don't provide great CPR, and that's on us. And so why we leave them there is because we don't want to provide a lower level of CPR. We want to provide high quality CPR to them from the start until the finish. And they have shown to have much better outcomes when we do that. So when do we transport and where do we transport to? As I said, when do we transport? Our average scene time for a cardiac arrest is about 40 minutes. Because once we kind of go through everything, the other reason that we don't move patients right away is because we tend to pull things off and pull things out. So if we have an IV in place, if we've put an airway in place, those tend to accidentally get pulled out when we start trying to move quickly. So it's all a very methodical approach to this. We like to call it in the EMS world a pit crew approach because everybody has assigned roles and responsibilities. And so I would say anywhere from that 30 to 40 minutes is when we start to actually transport the patient. And then where do we transport to? For us, we only transport cardiac arrest patients to a PCI capable hospital. So for us here in the Des Moines Metro, that's Iowa Methodist Medical Center or Mercy One Des Moines. And so, as I said, we operate off of protocols. This is another protocol, just basically outline where should we transport patients to. You can see that there's a lot more here as opposed to just our cardiac or STEMI, but we also do that with strokes, traumas, pediatric patients. We kind of help our providers tell them where they should go to the hospital at. So as a bystander, what happens next? And I think this is one of the most important things. It used to be that we would tell you how to provide CPR, and then we would come in, we would take the patient, and I'm one of those huge sticklers of I want to make sure all of our trash is picked up and nobody even knew that we were there, but the bystanders know that we were there. And we're pretty good at providing mental health care to the family members. We help them either get to their car or get into the ambulance so that way they can go with their loved one. But what about this Jamie who just now did CPR on a patient, on somebody that she's never met before? This might be the first time that she ever provided CPR. And that's a huge deal. I can still remember my first CPR from almost 20 years ago. And that is very can be a very uncomfortable thing. And not everybody's meant to deal with that. And so what we have adopted is we actually our supervisor will go to those bystanders and talk to them, and we actually have cards that point them to our website, our city website, and we have a lot of resources on our website for bystanders. So that way they can get help if they need help. And it may be calling one of these. This is just a screenshot. There are a lot more other things, but there's videos of, if you're feeling the X, Y, and Z, why don't you give somebody a call? Here's resources that are free and available to you to utilize. And so that's a huge deal. We like to stress the mental health of us as EMS providers, but it's also really important for bystanders to know that their mental health matters as well. And you shouldn't just have to provide the CPR to somebody that you've never met before and maybe will never talk to anybody about it again, but you shouldn't keep that bottled up. We know that that's not good. And so we have really adopted this, and it's gone over well. We also usually give them our supervisor phone number. So, in a week, they've lost the card, and they're just not quite sure what to do. They can get a hold of somebody, and we can point them in the right direction. So we get to the hospital, we transfer the patient over to the hospital staff. They continue to do their thing. But really, what happens after that? And so this is the same picture that I had posted before. There's a lot of things in here. As we pointed out, all these drawers have disposable things up here. There's lots of disposables. There's suction devices, and it'll be a very chaotic back of the ambulance. And so we have to clean all that up. We sanitize everything, so that way we don't pass germs from one patient to the next. We sanitize everything, and then we restock everything. And we put new linens on the cot. And then we go back and we start our report writing. But then we also do an informal debriefing. So we'll gather up the fire crew that was there, and then ourselves, and we'll talk about what went well and what didn't go well. What could we improve on next time? And this is just very informal, just kind of sitting around talking with one another. And nobody's going to get in trouble for anything that was done. We just want to see how could we improve next time. That also comes into our continuous quality improvement. Each one, as I said, all of our calls are 100% quality or gone through our QA QI process. And so another crew is actually going to come back and look at this report and say, hey, you probably should have done X, or you should have done Y. Did you consider this at all? And that's fine. It's not a criticism of that person. That's probably been our hardest part with that, is not to take those kinds of things personally. It's just we're trying to make everybody learn from every single experience. And then we get follow-up. We try to get follow-up on all of our patients. As I said, we keep very detailed, going back all the way to 2011. For here at West Des Moines, we have all of our cardiac arrest data. And so I could tell you what our bystander CPR rate was from 2012 compared to, last year. And so we keep all that data. And then we also upload to the CARES registry. And I think Leslie just put in the chat what CARES stands for, the Cardiac Arrest Registry to Enhance Survival. And so that really has a lot to do with pre-hospital care. And so we enter all of our information into there, and that goes to a national database. And that allows us to look at trends, what's happening each time that we give epinephrine, or each time that we give amiodarone, or what is the yearly walk out of the hospital rate for this particular area, or the Midwest, or we could even dive down into just the state of Iowa. And so that's always nice to be able to compare ourselves to the rest of the nation. So with that, that's kind of how a call works. As I said, we do a lot of training. So this is myself and Assistant Chief McCulloch. And we got involved with, you can't really see the number there, but it's 100%. We went up against all the crews with our CPR, and we outperformed everybody with our 100%. And so it just goes to show we try to have fun with our training, and so that way it's not just look at lectures and read papers. We actually put our hands on mannequins and go through all the necessary steps. So with that, I will open it up. If there are any questions, feel free.
Yeah, I will say I did have one. So since I was pretty rural, I was wondering what rural communities should do in terms of EMS. Like, what are your suggestions to them if they're waiting for emergency services for over like 20 minutes or anything like that? Do you have any tips for them?
Yeah, comforting the patient is the biggest thing as we start to talk about uh, a non-cardiac arrest. So somebody who's having chest pain. So you want to sit there and you want to reassure them and talk to them. And hopefully a first responder is able to, 20 minutes is on the longer end for a first responder to arrive, but it does happen occasionally, unfortunately, with Iowa being as rural as we are. I grew up in rural Iowa. My first EMS job was on a volunteer service. And so responding out into the county, but that's why hopefully there are first responders there that can show up and help you take some vitals. And I can say as an EMS provider, some of the key things that we're looking for are medication lists, advanced directives, which hospital do you want to go to? Those are all very important things to have prior to us getting there.
Brian, this has been great. I learned something every time I talk to you guys and meet with you. So yeah, maybe even elaborate on that further, right? So let's just say someone,
Did she freeze for everyone or just me?
She froze for me too.
Okay. Hey, Leslie, you had frozen, so we
I
didn't get
know.
to hear the
Uh,
question. Sorry.
yeah, no, it's okay. So, my question really was for those bystanders when there is a cardiac arrest, and let's just say they've never had CPR training and they just don't know what to do. Sometimes I get questions of like, how do I do CPR? How long should I do it for? What if I get tired and I just can't do it anymore? Or maybe just talk through for people that when I like to explain it that like just try, right? And then
Yeah.
what are those dispatchers how are they helping them, right? So you said that they tell them exactly where to press, but maybe help walk us through what those experiences are like for people, and that it shouldn't be intimidating. And
Yeah.
everyone always asks me about breaking ribs, so maybe go ahead and
Yep.
address that too.
Yeah. So great questions. But as you start CPR, or after you start CPR, unless the patient is waking up and trying to shoo you away, you should try to continue CPR the best effort that you can. So if it is that 20-minute response time for that ambulance, again, I hope that a police officer or sheriff or state patrolman, somebody like that, is able to be close by and show up. But you want to do as much as you can for as long as possible. and just continue giving it your best effort. Let's say that you are the only CPR trained person. Maybe you attended a hands-only CPR non-certification course, but then with the aid of that dispatcher, you're able to get going. But in this case, let's say Jamie is now tired and she doesn't feel like she can go any longer. She can grab somebody else and help coach them through starting CPR herself. So basically, she's becoming the trainer of how do I help this next person start CPR? And you can just rotate back and forth. Or, if there's more people to be able to rotate through, the better. We like to change. We actually do rotate every 2 minutes. So we don't even give anybody the option of, hey, I can keep going. No, you can't, because we know that after about 2 minutes of really high quality CPR, you can start to tire out. So the more people that you have, the better. But if you are by yourself, if you find yourself in that situation, the best you can do is just keep trying. For that person, and that will give them the best outcome possible. As far as the breaking of the ribs, there are noises that you're going to hear. And again, when I say that, it's unfortunately one of those noises that you're probably not going to forget, to be brutally honest. And it's going to happen. It doesn't necessarily mean that you're breaking the ribs. It could just be the cartilage separating from the sternum. But it is, I'm not going to downplay it. It is one of those sounds that kind of takes you aback and kind of jolts you and is like, oh, am I doing this right? Yes, you are doing it right. It's just unfortunately one of the things that has to be done in order to provide CPR.
Yeah, so people do always ask me, what if I break the ribs? I'm like, well, you might, but you don't always.
Right.
It's not always the case. But I always tell people that if you break someone's rib and you save their life, they're gonna thank you for breaking
Yeah.
their rib, um, kind of thing. Can you
Broken
talk?
ribs can heal.
Yes. Can you talk through any differences for children versus adults by chance?
Um, as far as bystander CPR,
Sure.
you want to provide the compressions, and as far as what I can think in my personal life, if it's my kids, I'm willing to give them mouth to mouth. There's not a whole lot of other people that I'd be willing to give mouth to mouth to, but if they're my own kids, a lot of times kids are primarily respiratory driven. Their cardiac arrest is respiratory driven, unless they have some previous heart issue. They're giving them those breaths, especially when they're your own kids, is can be important. And again, when those dispatchers provide the CPR instructions, it's just providing compressions. Um, you know, does that kind of answer your question about the pediatrics?
Yeah, and typically when we do trainings, we usually say for those young kiddos, it's kind of one strong arm instead of two.
Oh, yes.
For adults, kind
Very
of
good.
thing. Just and I'm sure the dispatch kind of helps them through some of those too.
Yep.
But there are a few differences. So when you're going to trainings, that's why we encourage people to do those trainings because there are some few differences that will help them. Is there anything that you wished people knew about your job that you feel like they don't know, or any myths you want to debunk, kind of thing?
I would say the big thing is that if you don't see us running, everybody always says you guys didn't run. And that is on purpose. We tell people not to run unless my life is in danger. A mountain lion is chasing me, I am going to run, or a bear is chasing me, I am going to run. But we purposefully don't necessarily run. We may walk briskly. But the reason that we don't run is not because we don't think that it's an emergency, but it's because when our heart rate starts to go up, our brain starts to stop thinking, and we start to get caught up in that scene. Whereas if we slowly enter that scene, we get to take everything in. Um, one of my mentors taught me the saying, you're a trained observer. And that's exactly what we're doing. We're kind of taking everything in. And that's how we train our paramedics is as you walk through that front door, what is your initial impression of the patient? What are you seeing? And so if we're constantly running up to that patient, what we call tunnel vision. And that's all we see. And there could be somebody else actually more hurt standing over or sitting over in the corner, I take for like a car accident. If somebody's screaming at me, telling me to come here, and I run up to that patient and I don't take in the entire scene, there could be somebody much more hurt than the person that's screaming. They may be making the most noise, but they may not actually need the help that I'm there to provide. And so I would say that's one thing. And then the second thing is just because we don't drive lights and sirens doesn't mean that we don't think that it's an emergency, or, we're not trying to downplay it. It comes back to that safety factor. Running lights and sirens is a very unsafe thing, both for us as EMS providers as well as the general public. And so for us, we only run lights and sirens on approximately 7 to 10% of our transports. Cardiac arrest usually falls into one of them. Strokes is another one, a STEMI is another one, or a surgical emergency. Those are our big ones that we will run lights and sirens, because there is a slight savings in time with running lights and sirens, but for our general calls, there's not enough savings. We can provide a lot of the initial treatments that the hospital can provide in the back of our ambulance and do it in a safe manner.
Yeah, those two are great for people to know, because I think, yeah, they will think, why are they not running? Why are the lights not on? Let's see, Caitlin, did you have any other questions right now?
I don't think so. Okay. Well, I just want to say thank you so much for presenting for us. I definitely learned a lot. There's a lot of misconceptions that I had in my head, especially about the lights. So I'm glad that you were able to elaborate on some of the stuff. So I will just share this really quick. Thank you. And feel free to keep an eye on our social medias for next month's webinar. And yeah, thank you so much for joining.
Thanks, Brian.
Thank you.